So acute graft-versus-host disease, as I said, it's probably the most common side effect of allogeneic transplantation. It affects 40 to 80% of all comers, but this is why the range is so wide, because there are many, many factors that affect this. The intensity of the conditioning regimen, myeloablation versus reduced intensity, T-cell depletion or T-cell repletion, the use of ATG, oral Campath, or similar T-cell depletion agents. So acute graft-versus-host disease, classically, it occurs in the first 100 days. We say classically because there's a huge overlap. I have many patients who develop acute graft-versus-host disease at 6 months after transplant. And when we talk about chronic graft-versus-host disease, which classically occurs after 100 days, I have many patients. We have in the community of transplanters, many patients that will develop chronic graft-versus-host disease before day 100. Acute graft-versus-host disease is more of an acute inflammatory T-cell mediated and cytokine induced phenomenon. Affects, again, classically, the skin, the upper GI, lower GI, and the liver. How and when is steroid-dependent versus steroid-refractory acute graft-versus-host disease defined? The question is loaded, and let's dissect it a little. What is the definition of steroid-refractory acute graft-versus-host disease? The definition in the consensus criteria is one of the following three. After 3 days, progression of acute graft-versus-host disease. After 7 days, no improvement. After 28 days, no resolution of acute graft-versus-host disease. Let's say this again. What is the definition of steroid-refractory graft-versus-host disease, acute graft-versus-host disease? The definition is with glucocorticosteroids that is equivalent to prednisone 2 milligram per kg per day or more as a first-line treatment. Let's say someone starts with grade 3, like our patient, on Friday. By Monday, they went into grade 4. Or by Thursday, they still at grade 3. Or fast forward 4 weeks later, despite a good dose of corticosteroids, there is no improvement. That is the definition of steroid-refractory acute graft-versus-host disease. What is the definition of steroid-dependent acute graft-versus-host disease? At the maximum dose of steroids, 2 mg per kg, prednisone equivalent per day, there is some improvement, but as soon as you go down, taper down the steroids, graft-versus-host disease flares back. So that is the definition of steroid-dependent. So we have steroid-dependent and steroid-refractory. The approach to both is the same. You go into a second-line treatment. The prognosis for both is exactly the same. 50% treatment-related mortality at 6 months, 60% treatment-related mortality at 1 year. Response to second-line treatment, the only approved second-line treatment, ruxolitinib, is approximately 50 to 55%. Now that we went into the definitions and the prognosis of patients with both steroid-refractory and steroid-dependent acute graft-versus-host disease, what is the best approach for steroid dose tapering after initial response? The most common phrase that we say in the floor as transplanters is, we hate steroids. Steroids cause a multitude of side effects. Patients get deconditioned, they can't sleep at night, immune suppression, diabetes, and multitude of other problems. So we like to taper down the steroids as soon as possible. There are no real guidelines, and we have to take it as we go. I have a patient upstairs who's older in the 70th, so I am eager to decrease the steroid faster than someone who's in their 30s, just because of their deconditioning and diabetes and other problems. So in short, we taper steroids as soon as we get a response. The dilemma is, sometimes it's very hard to do that, and when we taper steroids, the graft-versus-host disease comes back.